committee for this work, for this organizing this webinar and this series of webinars. On behalf of Kristen and myself, we're really excited to be able to be here today and share the work we've just recently published and we're busily working on last summer. So Martine has just read the title of our work here on the slide. And you are able to see my slide. Thumbs up. Super, thanks. So we all know that in 2020, COVID-19 really affected numerous people around the world. And we also have become more aware of who is most vulnerable to the negative effects of COVID-19. And this includes persons who are over 60 years of age. Coincidentally, persons who are over 60 years of age also comprise nearly 9 out of 10 cancer diagnoses. And so this makes this group an important group to study during the pandemic. We know that cancer survivors have a number of unmet needs after they complete cancer treatment, and this includes things like their need for psychosocial support or need for informational support. And we know that those first 6 to 12 months after treatment are identified as the most difficult by them. Post-treatment presents additional challenges for older adults who have an increased likelihood of pre-existing comorbidities, sometimes multiple comorbidities, as well as having functional impairments due to the aging process. And we know that prior to the pandemic, most of our life was in person. So these resources were provided face-to-face, but because of restrictions related to COVID-19 and physical distancing, most resources are no longer available or adapting to become online. So we developed 4 research questions among a population group of persons who were older than 60 years of age, who have been diagnosed with breast or colorectal cancer, and who were discharged from their care of their cancer team within the preceding 12 months. And so in this group, we asked 4 research questions. How does COVID-19 affect their access to formerly used and or the desired resources or supports that they had? Secondly, what coping resources were they using during the pandemic? And thirdly, do these resources help them or not to meet their cancer-related needs? And finally, we wanted to hear their reflections of the pandemic and what their suggestions were for what would be suitable resources or delivery methods when we weren't able to get together traditionally in face-to-face manner. So to guide our work, we used Moose and Hallahan's coping framework, which is on the slide here. And this framework describes a number of interconnections among our characteristics, such as our personal and our social resources, which influence how we cope with stress in our lives. So for this study, we were particularly interested in how older cancer survivors, they drew upon their I don't know if you can see my mouse, but their personal system and their environmental system. And so by personal system, this includes their personal resources, such as their own characteristics, what is their dispositional coping style, what is their cognitive or intellectual ability, as well as their general personality traits. In the environmental system, it also encompasses relatively stable characteristics, but includes things like ongoing life stressors, and this could be related to physical health or finances, but as well as social resources and the relationships. And collectively, these systems interact to affect the individual's psychosocial functioning and well-being. And so we used a convergent mixed methods design where we collected quantitative and qualitative data in parallel. We analyzed this data separately, and then we merged them to maximize our interpretation of the findings. So you can see here on the left of your screen, the quantitative data, we use the brief COPE questionnaire. And this is valid and reliable in cancer survivors. And it includes 28 items that assess 14 different coping strategies or types of responses. We used SPSS to analyze this data descriptively using descriptive statistics. On the right of your screen, you'll see the qualitative process that we followed. So we conducted one-on-one telephone interviews um, where we asked individuals what were their individual coping resources that they used, both pre and during COVID. What sorts of formal or organized coping resources did they use, again, pre and during COVID? We asked them what they believed their personal characteristics or their attributes were that helped them to cope during the pandemic. As we then discussed with them in the interview, we wanted to know what sort of changes occurred in their lives that were important to keep after the pandemic, that were important to help them cope with their cancer-related concerns, as well as what their recommendations would be for future delivery and resources to cope. We analyzed this descriptive data using a descriptive thematic analytic approach, where Kristen and I met weekly to discuss codes and subthemes and themes so that we could have a real inclusive description of what their perspectives were. And we used NVivo 12 to facilitate this process. So we had a pool of 89 cancer survivors, colorectal and breast cancer survivors who have been discharged from our center within the preceding 12 months. The center's Cancer Center of Southeastern Ontario is the acronym there. But because we couldn't interview all 89 participants, we used a stratified sampling approach with the age categories listed here on the screen. All persons in the pool identified as either male or female, and so we had a stratified by gender so that we could have a representative perspective of both genders. And so in the end, we had 30 participants. And so this sample was on average 72 years of age, and their ranges from 63 to 83 years of age. And there were 17 female and 13 male participants. Most of them, or 76%, were married or common law, and 93% of them identified as Caucasian or retired and not working. We had equal numbers of the sample who had been diagnosed with breast or colorectal cancer, and most, or nearly 97%, had completed chemotherapy that was completed on average 20 months previously. So this slide indicates what the brief COPE results were, and most participants used coping strategies that stemmed from their own personal system, and that's reflected at the top of the screen here. We see that most commonly used personal system resource was accepting, which was employed by nearly 97% of participants, or distracting themselves from their situation, which was employed by 93% of them. But also 93% of them said that they took actions, active actions to engage in their situation. At the bottom of the screen are the environmental type coping strategies that they use. And these were used less often than their personal system strategies, where most participants used instrumental, we can see here, or emotional support to cope. So in getting to the qualitative information, Kristen and I developed 3 themes to describe this, the participants' narratives. First is drawing on lived experiences. Secondly, redeploying coping strategies. And thirdly, the complications of being a cancer survivor during a pandemic. And I'll just describe each of those here. So firstly, the multifaceted experiences of these older cancer survivors, it shaped their coping, the strategies that they had learned throughout their life. And this included their cancer diagnosis, through their cancer journey, other illnesses they had, but as well as their life and their work experiences. Most commonly mentioned, though, were the experiences of illness, whether that be cancer or non-cancer, by themselves, their own personal experiences, or of someone whom they know quite well, such as a spouse, parents, friends. Some participants described how they enacted coping strategies during these former illness experiences, and that they continue to use them even now during the pandemic. One participant said, "I don't find it such a change because the things I'm doing, I was doing after I got my cancer diagnosis anyways, because I wouldn't go near anybody when my immunity was so low. So that's helped." In this way, although cancer survivors are seen as doubly vulnerable, they focused on their strengths and their coping capacity that they had gained during their prior illness experiences. Participants also cited various life experiences and how these informed their coping strategies at this stage in their life, of which the aging process was the most commonly cited. One participant said, I didn't have children I had to worry about shopping for. My parents are deceased. So really, this pandemic hasn't been that hard for me. And finally, work experience influenced how older cancer survivors coped with their cancer-related concerns. Most notably was the impact of being or of themselves being or being the spouse of a healthcare professional who had a background in health and knowledge of healthcare matters. Furthermore, one participant was a healthcare professional who provided care up in northern Canada. And so she drew upon these experiences to cope during the pandemic. She said, I have lived in isolation. I had all these supplies in that you would use for being isolated. I did it as routine. Second theme is that the coping strategies used by older cancer survivors during the pandemic weren't new. They were redeployed or repurposed during the pandemic. One participant put it plainly. She said, absolutely everything is easier post-cancer and chemo. Some participants tried to continue on as before the pandemic or even magnify their formerly used strategies that they had used before the pandemic and use them now during the pandemic. One participant said, I'm using my cleaners more, but I was always very particular about that anyway. Participants cited a variety of activities that kept them distracted from the pandemic and any concerns that they were experiencing related to their cancer. And one participant, she illuminated this for us, as indicated, she crocheted dishcloths and hand towels. And she said, that's like my therapy to me. It keeps my hands busy. It keeps my mind going. And it keeps my mind off all the other things. Because if you sit and you don't do anything, that's when you run into trouble. As for your mind wandering, and you can get yourself really, really worked up. And the third theme about complications of being a cancer survivor during the pandemic. And sometimes they observed that there was this dissonance between coping strategies that were available to them versus those that were familiar. And so this sometimes made it challenging to cope with their cancer-related concerns. One participant stated, it's different. Like even fishing. I've been going fishing by myself rather than take somebody with me, but it changes the way fishing is. It's just, there's nobody to talk to or shoot the breeze with when you're fishing. And this was particularly true for participants who continued to experience side effects related to their cancer or their other illnesses, which hindered their ability to engage in activities that they formerly enjoyed. Sometimes participants actually resigned from the activity altogether, while others continue on with the activities, but they had a different level of expectation to complete the activity. One participant said, before the pandemic, I would do a lot of activities and exercise because that really helps me with the condition. And she's referring to her comorbidity here. While I was exercising, I was doing quite well. But because I'm not able to go to the gym anymore, it causes my condition to worsen. So that has had a huge effect on me. And now I'll pass it over to Kristen.
Thanks, Jacqueline. So one of our research objectives was to determine recommendations for future care based on participants' experiences during the pandemic. So participants really identified 4 major recommendations. The first was for enhanced baseline information. Participants valued the expertise of their oncology teams, their knowledge, but the sudden change in health services left them feeling very unprepared. They felt more could be done to better prepare older cancer survivors to engage and to understand how to manage their survivorship period should there be interruptions in care. So some of the suggestions that they made have a sort of durability that would extend beyond the pandemic. For example, providing discharge summaries, written discharge summaries, and also providing written summaries after every in-person visit, rather than just at the time of discharge from the cancer center. That also has implications for older adults, being able to share that information with their spouse or loved one or caregiver if they aren't able to attend those visits. The second recommendation is to facilitate caregiver support and engagement. We're all familiar that there have been changes in visitor policies which vary from different locations. But this was a huge concern for survivorship follow-up appointments in this jurisdiction, where essentially no one was allowed to attend the visits except for the individual themselves. So participants felt it was important to think creatively about how to facilitate caregiver involvement, and this was a critical point. So one of the individuals who was a caregiver actually asked if she could join the consultation by phone. She didn't need to go in person, but she would sit in the parking lot and go by phone because the person that she was a caregiver for didn't have had some cognitive issues and had memory issues, and so she was very concerned about them attending the appointment by themselves. So that was a suggestion that she had made. Older survivors of cancer also recognized the need to pivot to more use of virtual and telephone visits, but wanted support to engage in such measures and felt that technology could be used more for some things and less for others. For example, I think many individuals were using things like Zoom to attend physio appointments or other socialization activities, but older survivors really did not like the follow-up appointments with their physicians being held over the phone, particularly when they had a pre-identified concern that they were actually phoning specifically to be dealt with. They didn't feel that it was really attending to their needs. The last point is sustained use and public appreciation of PPE. Participants really valued the expanded use of masks and PPE and felt the pandemic might increase awareness of the need for masking and PPE used to protect those vulnerable to common illnesses like cold and flu, even after the current pandemic. Because older adults had experienced this period of vulnerability, many of those who had had chemotherapy, and they felt it was actually a respectful thing and hopefully a positive societal change that again would have that durable effect after the pandemic. So we'd like to highlight a couple of strengths and limitations of this study. The strengths would be that we had quite a diverse sample in terms of the age through that stratified sampling approach. And also, we know that this is a current issue, as was identified in the guidelines that were lead authored by Nicolo Battisti, that there's not a lot known about the older adult cancer experience during the pandemic, of course, and less known about older cancer survivors. So this is providing some initial information to grow that knowledge base. There are limitations, of course. One of the key limitations that we found was that we did not collect or have information about functional status. And that sort of came through in some of the interviews that we were conducting where we were getting that sort of variation, but we don't have anything concrete to sort of anchor those impressions to. The timing of the recruitment in the survey is also, or the study is also really important because it was summer in Canada. People had different perspectives, and we'll highlight how we're addressing that in just a moment. And lastly, just that response bias can be identified as an issue. This is a small study and it's from a existing pool of participants. But of course, that is not the goal of this study. The goal really was to provide a description of these individuals' experiences. So a couple of study implications. Clinicians can engage a strengths-based approach to support older adult cancer survivors that they draw from their past experiences, which seem to contain a vast repository of potential coping skills. We find it very interesting and important to note that older adult cancer survivors did not see themselves as vulnerable. They did not identify with that sort of poor older person characterization. They felt very independent and felt very confident for the most part. These study findings can be used to inform the development or enhancement of cancer and non-cancer resources to support coping, particularly using remote delivery methods where patients and survivors can attend in person within and beyond the pandemic. And as I mentioned, one of the things we noted is that this is a cross-sectional approach using quantitative language, and so we did just conduct one interview in the summer between July and August, but we're now conducting follow-up interviews. So we've talked to most participants once again, so it's 6 months later, and it's the winter, and it's a hard lockdown taking place in the jurisdiction. Perspectives have changed a lot. There has really been an evolution, both in their understanding of the pandemic, as well as sort of the psyche, which we all know, we're all going through this together. And we're also conducting a gender analysis based on those initial interviews and the ongoing interviews and the subsequent interviews we'll conduct. So we'd just like to briefly acknowledge the funding that was received for this part of the study by Dr. Galica from the Rapid Response Fund at Queen's University and acknowledge our co-investigators. And we'd also just like to invite you to reach out and ask questions to us through email or on Twitter. And we've identified here the publications where you can read more about this work. I'd like to thank you all again for participating in the webinar this morning. And we're really happy to first listen to Dr. Krok and then answer some questions. Thank you.
Thank you very much, Jacqueline and Kristen, for this excellent overview. Then we'll first go to Dr. Jessica Krok. She's an assistant professor at the Division of Health Sciences, School of Health and Rehabilitation Science at Ohio State College of Medicine. And she completed a postdoc at the NIH Center for Population Health and Disparities at the Comprehensive Cancer Center in Ohio. And her research focuses on cancer survivorship, symptom management, and behavioral intervention. So Jessica, the floor is yours.
All right, thank you very much. And I'd like to thank Martine and Kristen for this wonderful invitation. And so I guess I don't have to introduce myself. So the title of my talk today is Cancer Care Providers Care for Older Adults with Cancer During the COVID-19 Pandemic. So this is a nice kind of bookend to what Kristen and Jacqueline were talking about. So now we're going to be talking about from the provider perspective. So I'd be remiss if I didn't acknowledge my co-authors and collaborators. First, this was a joint effort in the Cancer and Aging Research Group, so better known as CARG, the Advocacy Subcommittee, and that's led by Armin Sharokny as well as Beverly Kanan, but Carlin Britzenhofzog and Emmy McKenzie, as well as my PhD student Janelle Pacino, were big collaborators on this project. We also worked with the Association of Community Cancer Centers, the ACCC, with Alania Plotkin, as well as Lee Bomer. And I want to also acknowledge the Association of Oncology Social Work and Social Work Hospice and Palliative Care Network. Okay, so today I'm going to be talking about two papers. They're really two like sister papers originated from a survey of healthcare providers of older adults with cancer. So the first one is on the left, that presents the quantitative results, and on the one on the right presents the qualitative results. Okay, so this is kind of what was talked about a little bit before, but from a provider perspective, providing excellent oncologic care to older adults with cancer is challenging. This is primarily due to a lack of evidence-based treatment options and guidelines for treating specific cancers among older adults. And the management of older adults with cancer across the disease trajectory has significant challenges such as comorbidities, frailty, and polypharmacy. And the challenge to care for older adults with cancer has been intensified during this pandemic. And there's been a call for cancer-specific COVID-19 guideline development and uniform implementation of those guidelines. And the pandemic continues to pose a barrier to equal and evidence-based management of cancer in older adults. And further, older age and comorbidities such as cardiovascular disease, diabetes, chronic respiratory disease, chronic renal impairment, as well as cancer, has been shown to increase risk for worse outcomes from COVID. Also, the delay and cancellation of elective treatments, strict policies limiting visitors for inpatients, and the transfer of follow-up care from in-person to telehealth have all led to concerns on the part of patients and providers. And healthcare providers have had to acknowledge critical unknowns of how these changes may affect the clinical outcomes of older adults with cancer. And we're still going to be finding that out in, frankly, years to come. So our aim was to learn about the experiences, including the practices, concerns, and care delivery barriers on which oncology healthcare providers are experiencing or observing among older adults with cancer during COVID-19. And we had specific considerations for this study. We really wanted to look at the provision of and concerns of cancer care for older adults, decision-making regarding cancer treatment and do not resuscitate orders, as well as the barriers and facilitators related to the care of older adults with cancer, particularly regarding telehealth, because there was this proliferation of telehealth. So in the spring of 2020, the Cancer and Aging Research Group, specifically the Advocacy Committee, developed a Qualtrics survey for the multidisciplinary team members of those responsible for direct care of older adults with cancer. And to be eligible for this survey, we kind of kept the eligibility criteria pretty broad. We sought to include individuals that provide care for people with cancer, that they're willing to participate in the study voluntarily, and that they understand that the results may be reported in multiple publications, which you've seen previously. We're hoping to look for to publish maybe 1 or 2 more additional from this this survey. And the eligible participants were recruited by emails sent through 4 professional organization listservs and email blasts, as well as social media messages from people like myself on Twitter, as well as Facebook, with the request to forward the survey to any other care professionals. And we quickly developed this survey, and we only had a short study period. The reason why is because we just wanted to collect what was happening and then get that information out there. So we collected it basically in the month of April of last year. So the first article I'm going to be talking about, this is focusing on the quantitative survey items regarding caring for older adults with cancer during COVID. And so we were focused on a number of questions. So there was 20 questions in our survey, 17 were the quantitative ones. So they explored the prioritization and rescheduling of cancer treatments, the receipt of guidance for decision-making, the existence or lack thereof of written guidelines regarding the management of older adults with cancer during the pandemic. Participants were also asked about their level of agreement regarding 6 scenarios of DNR orders among older adults with cancer who were COVID-19 positive, as well as potential age cutoffs for automatic DNR orders. Other questions asked about barriers associated with the use of telehealth and increased barriers observed among older adults with cancer. And lastly, we wanted to collect some brief information about the participants' professional history. So the figure on the right shows that most respondents were either social workers or medical providers, advanced practice providers. The others category, that yellow wedge, were oncology nurses, research nurses, dietitians, case managers, medical assistants, that sort of thing. More than 2/3 of our participants reported that the majority of their patients were older adults. The vast majority of respondents were based in the United States. Just over half the respondents practiced in urban settings, 30% were in suburban, and 17% were in rural areas. And just over 1/3 reported working in an academic and National Cancer Institute Comprehensive Cancer Center setting, followed by about 29% in community cancer programs and 17% in hospitals. So participants were asked to indicate how strongly they were considering postponing or rescheduling treatments by age group. And so we're actually going to start at the bottom of this figure. And I want you to pay special attention to the yellow and gray lines, which denote the responses of strongly considering or considering. And so at the bottom, we found that about 17.5% of respondents were strongly considering postponing or rescheduling treatment for younger patients, those individuals aged 30 years and younger. However, you can see at the top of the figure, it shows that 46% of respondents were strongly considering postponing or rescheduling treatment for patients aged 85 years and older. So this figure shows, why they were considering that. So these are kind of the top considerations for postponement or rescheduling those treatments. And the top 5 reasons for postponement or rescheduling were comorbid conditions at 72%, cancer stage at 70%, frailty also at 70%, performance status, and age. And I do want to note that our sample is biased. So they were people who work with older adults, and these considerations may differ compared to medical providers as a whole. So participants were also asked to identify their level of agreement with 6 scenarios that are seen on the left here regarding DNR orders for people with cancer who are COVID positive. And seen at the top of this figure, most respondents strongly or somewhat disagreed that all patients with metastatic disease above a certain age should be automatically made DNR. That was about 74%. Just under that, more than 70% of respondents strongly or somewhat disagreed that all patients with metastatic disease should automatically be made a DNR order. And then at the bottom of this figure, you can see the large majority of respondents, about 83%, strongly or somewhat agreed that the decision regarding a DNR order should be the result of shared decision-making with the patient and the healthcare proxy when the time and resources permit. And lastly, 86% of respondents supported shared decision-making conversations regarding DNRs at every scenario. So this table just shows the common sources of support and guidance for decision-making during the COVID-19 pandemic. And the most common sources were other oncologists, so that was 61%, medical directors at 56%, and administration, so through the health system or their institution at 54%. So participants were asked to rank their top 5 concerns related to the pandemic out of 11 options, and patient safety was the top concern at 84%, followed by treatment delays at 65%, and understandably, healthcare worker mental health and burnout at 57%, PPEs at 56%, and their own personal safety at 54%. So it's important to note here that the providers were concerned more about their patient safety, and it was above their own safety. So switching gears, let's look at the barriers using telehealth with older adults with cancer. And the 2 most common reported barriers to the use of telehealth were patient access, such as, they didn't have smartphones or high-speed internet. That was 91%. And patients having technology challenges, which was 90.5%. Additionally, 44% of respondents said that patients' perception of telehealth was a barrier. So this was alluded to by Jacqueline and Kristen. Older adults tend to have a strong preference for face-to-face care compared to virtual care. Another patient-related barrier was a concern for patient safety. So the prescribed treatment regimen was not necessarily transferable or appropriate to be implemented through telehealth, and that was at 31%. Other barriers included infrastructure access, with institutions or programs, even healthcare workers having tech issues and issues with the healthcare workers' home and work environment. So this research stresses the importance of training the general population of medical providers and policymakers in geriatrics. Our sample, like I said before, was unique because the majority of the study sample regularly provided care for older adults with cancer. And given the current resource limited climate, coupled with the current visitor restrictions, shared decisions about DNR status at the bedside may be more challenging than ever before. So it is critical to have those DNR discussions and documentations prior to urgent medical needs. And this has been, the hallmark of geriatrics for quite some time. Withdrawal of the formal and informal functional supports on which many vulnerable older adults rely on can negatively impact their current cancer prognosis, as well as their physical and mental health. And so one way to address the needs of older adults, and particularly those with cancer, has been through technology. We've all benefited. We're doing this via Zoom right now. So as we see in this study and in the literature, there are some major barriers to this. So, clinicians should be aware of these difficulties and consider some simple common sense interventions that are beneficial to both parties and appropriate based on medical need. And they, at the same time, keeping their patients safe and avoiding unnecessary exposure to COVID while continuing those therapeutic relationships in cancer management. So moving on to kind of the qualitative part of this. So these were 3 questions from our survey, and we had 3 open-ended questions, and we asked the respondents to list up to 5 clinical barriers caused by COVID-19 as they relate to caring for older adults with cancer, to list 3 questions regarding COVID-19 being asked of them by their patients with cancer, as well as just kind of an open-ended share your experiences as a member of a cancer care team during the pandemic. And these 3 open-ended questions were analyzed using qualitative context analysis by 2 separate coders, myself and my PhD student, using in vivo 12. And all kappa coefficients were greater than 0.8, indicating excellent inter-rater agreement. So I alluded to this earlier, but 92% of our participants were from the United States, but I wanted to represent who was answering our survey. So this map shows the distribution of the study's participants by country, and hopefully some of them are even listening today. So emergent themes from the clinical barriers reported by providers were grouped into 5 common categories. So the first was organizational challenges in care provision. Also the patient's access to resources and support, the patient's mental health status, telehealth challenges, and the patient's physical health status. And so let's go into these themes a little bit. So examples of organizational challenges in care provision included delayed cancer care, such as mammograms, biopsies, and scans among older adults with cancer. Examples of patients' access to resources and support included the interrelated issues of transportation, the limited caregiving support due to stay-at-home orders and social distancing, and difficulty accessing food and supplies, which were often provided by caregivers. The third column, the mental health status, was also a major clinical barrier as well. Social isolation greatly affected the patient's mental health status. They had reduced caregiver and family support, to ensure their own personal safety and their caregiver support. And then there was also issues regarding the strict visitor guidelines in the clinical settings. Telehealth challenges were particularly for older adults with cancer was communication difficulties in terms of physical impairments, so sight and hearing and speech, and also the technological difficulties such as the patient's technology ability. We just threw them into this, and so there was a steep learning curve. Sometimes there was inadequate equipment and spotty internet. The last clinical barrier that we're seeing is the physical health status, and that includes geriatric syndromes such as comorbidities, frailty, functional limitations, as well as being high risk status. So, being an older adult coupled with being immune suppressed, due to your cancer treatments. So the questions asked of providers by older adults with cancer were grouped into 3 themes. So the patient's health and their cancer care, the basic needs and support of the older adults, and future and pandemic timelines. So let's go into these themes a bit. So the most common question of providers was concerning patients' health and their cancer care, particularly regarding the risks and benefits in delaying these treatments and procedures, as well as how to keep themselves safe from contracting COVID. The second there regarding basic needs and support regarded the balancing act of safely accessing basic needs and support, including food and supplies from their caregivers, and then including their caregivers at appointments for their cancer treatment. And this was especially difficult, like I said, because of visitor restrictions at the clinical settings. And then a common question under the last column is one that we all have and we currently still ask, is that providers regularly fielded questions regarding estimated timelines of when one can return to the cancer center or hospitals and when restrictions will be lifted. So the most interesting and insightful part of this paper was the open-ended question, which asked participants to share their experiences as a cancer care team member during COVID-19. And so some providers worried about their patients' mental health, considering the isolation, the reduced support, and the threat of serious illness, on top of their current cancer status. There were also feelings of crisis and fear of personal safety among the healthcare providers. For example, one provider said that he was afraid to get sick and die, and he's afraid to get his patients sick knowing that they will die. And then there were also frustrations and anger at multiple institutions. Providers were especially upset about the lack of PPE, They felt overwhelmed due to inadequate staffing, and they were frankly really disheartened by the lack of leadership from the US federal government. And however, there are some silver linings to this. So some respondents reported positive feelings that they were inspired by the teamwork, communication, and even their own institution's preparation. So it's been 9 months since the survey was implemented. So I do want to stress that, just like how Jacqueline and Kristen did, that it takes a while for the research to come out about this, but I kind of think that the themes are still there. So there's a need for resources and support allocation for older adults with cancer, as well as their healthcare providers. And there's a need to ensure this continued flow of care and to provide the infrastructure of patient access. Another major finding was that the providers' concerns focused on their older patients were above their own and their own family's safety. And so this illustrates the devotion of these providers regarding their own patient population for older adults with cancer. So given the physical and emotional toll, though, it is imperative for both patients and providers to receive resources and support during this difficult time. And lastly, both parties, the providers and their patients, need to have access to these support services to minimize the long-term negative outcomes of the difficult choices and the psychosocial upheaval that they continue to face even today. So I do want to stress that it's essential for nurses and social workers to play an active role in facilitating discussions about do not resuscitate orders among older adults with cancer, their families, and other members of the healthcare team. Nursing and allied health professionals should be aware of patient barriers discussed today, both in my talk as well as Jacqueline and Kristen's talk, and consider simple common sense interventions that are beneficial, appropriately based on medical need, and avoid unnecessary exposure to COVID while maintaining those therapeutic relationships in cancer management. And some action items can include connecting older adults with cancer to local food banks, appropriately identifying and assessing the availability of a caregiver along with caregiver burden, and working with the Area Agency on Aging to coordinate safe rides to their appointments for treatments. And so I'd like to thank you. And this is my contact information if you want to reach out. I know that sometimes it's hard to get a word in, especially with these web-based webinars. So I thank you very much.
Thank you so much, Jessica. And thank you so much, Kristen and Jacqueline. I see we have one question already on the chat, but if anyone has questions, I'm just going to try to see how I can, is there any way that I can allow you to talk? Okay, I think I can allow people to talk. So if you, let's go to the first question and then I'll unmute everyone so that you can speak. Where did my webinar go? So the first question is from Sandy. Is there CMS reimbursement for telehealth ACP discussions? So I think that is probably for someone in the United States.
Yeah, so I think that's me. So there is reimbursement. So that was actually one of the major hurdles when this whole thing started, frankly, when this giant shift to telehealth. So there was about a month lag in the reimbursement allocation, but yes. And if someone else can speak to that too, I'm not really privy to the ins and outs of those reimbursements, but that's something that that there was a bit of a lag, but now they are covered. The question is are these reimbursements long-term? So is this going to be a continued practice, after hopefully we reduce COVID and can all get back to somewhat normal lives after this?
Thank you. Other questions, and I allowed everyone now you should be able to unmute yourself if you have any questions.
Yeah, so Supriya just chimed in and she's from the West Coast, so I hope you have lots of coffee, Supriya. But she said, yeah, it's correct. They're covered now, but in terms of the longevity. Oh, East Coast, I'm sorry. I'm used to City of Hope people, and I don't see anybody of those people on. So sorry, Supriya, I forgot that you're at Rochester.
Can I just add on to that question too? I think that's one of the concerns around the whole telehealth virtual pivot that's happened, is that people are feeling like it's going well and it's an accessible way. Certainly for me, I'm happy to attend a doctor's appointment at home instead of packing up all my kids and taking them to the doctor, my mini children. But that doesn't work for older adults. And so I think that's really the pause here that's taking place. And that's why some of this research is really important, because we do need to think about this long and hard. And if we are going to do this with everyone, really think about how we facilitate it appropriately, because there is really sort of like, oh, this is great, this is working really well, we can do this for everyone, we need less office space, we need less clinic space. So I think there does need to be a bit of a pause and consider the implications on everyone.
I'm going to do a plug for my own research. So I'm currently collecting that exact thing and say, it's answering the question, if we build it, will they come? So we're asking from a nationally representative survey as well as semi-structured interviews with older cancer survivors. Hey, what do you think of all of this? Like, did you use it before? Are you going to use it in the future? What are some ways that we can improve upon it? So stay tuned. This is our we're closing the project at the end of this month. So hopefully maybe with upcoming conferences, you'll see some of those results.
Well, that's very exciting. That will be a webinar in the future after you finish that work.
I'm around. Sure.
Any other questions?
I do want to say that one of our panelists, Elizabeth Arthur, is my primary investigator on that. So I do want to say that I want to give out a shout out to my colleague as well.
I also see we have, and this is me not knowing the bigger Zoom version, we have a question from Carolina. She says, thank you very much for the information. Regarding the first presentation, I wonder if you compared your survivor data with pre-pandemic data. For instance, people who survived cancer perhaps 5 years pre-pandemic. Do you think you could give us some more insight on their cancer survivor needs? Kristen or Jacqueline?
Yeah, that's a really great question, Carolina. No, as Kristen indicated, this was a one-time survey, a cross-sectional survey. So we were just asking about what they were using at that point during the pandemic. But it's a really great consideration for looking back even farther pre-pandemic. Kristen's actually leading some follow-up work from our work about how these sorts of needs or changed or coping has evolved during the pandemic as we get deeper into our isolation and winter in Canada, where we are not able to get outside as freely and or as much as we would like. But this was I'm putting on my quantitative hat now, and I'm thinking this was a small sample of 30 participants, and so there wouldn't be any sort of comparison that we could do retrospectively, although it's a really great idea to do some looking back and looking forward. I agree with you. Kristen, do you want to add any thoughts?
No, I don't have anything to add. I agree. I think that some of those, if you had a cohort and you could, follow them, we didn't have that. That wasn't the design. But I think the forward looking, what we're seeing now, even 6 months later, has made such a big difference. So yeah, that will be interesting.
It may be something that can come out of, I know that the Canadian Longitudinal Study of Aging, because they were collecting data before, and I'm sure the US longitudinal aging studies and the European longitudinal aging studies, because they had lots of data collected prior to the pandemic. And I know the CLSA is collecting additional data on pandemic experiences and things like that. So that might come out in the future as well from these longitudinal aging studies, because they would have the comparison groups before and after and during the pandemic.
I do know one large data set based in the United States, the Women's Health Initiative, They are asking all participants to fill out questions about, delays in medical appointments, all of that, psychosocial, all that. And they do have a cohort of cancer survivors. So I'm sure that you could answer those questions utilizing the WHI data set.
May I ask a question of Jessica?
Yeah.
Really, really important and interesting work. And when you showed the world map of where your respondents were, and the vast majority of them were from the United States, but there were quite representative of, like around the world. I'm wondering, although that you couldn't have made a formal comparison because of the different sizes, I'm wondering, was there anything you just kind of went, I wonder if that's because they're not in the US, or I wonder if that's because they are in the US?
So that is actually one of the papers that we're taking a look at the data right now. So so the two additional papers that we're thinking of from this data set is looking at the urban versus suburban and rural settings, as well as US versus outside of the US. So I don't want to group them in the same category, but we are taking a look at the data. A lot of us the semester started for us, so things are a little busy, but those are the two papers. So you hit the nail right on the head, Jacqueline, in terms of future directions. So we're going to take a look at that. But in terms of, power and all of that other things, it may be, a little bit lower. And that too, it's a cross-sectional, and our sample size for the international group is a little bit smaller, but we're taking a look at it. Great question.
Thank you all so much. We're at the one at 10 o'clock here in Toronto, so at 4 o'clock in Geneva time. So I want to thank everyone for joining today. I want to thank our speakers, Jessica, Kristen, and Jacqueline, for doing a great job. It is recorded, so Laurence will send out the link to the recording after. We hope to do this on a monthly basis. Next month, so save the date. I hope to send out the invitation shortly. It will be February 18th, so next month in a few weeks. It will be 12 Toronto time, which is 6 Geneva time. And we will have Dr. Soda Sattar and Dr. Mackenzie Percolotti, and they are going to tell us all about the how and what of physical performance testing, etc. So please join that webinar as well. And then I wish you all a good afternoon, good evening, or a good, good morning, and some breakfast for the ones on the West Coast.
Thank you.
Bye, everyone.
Thank you so much.
Thank you. Take care.
Thank you so much.